We are very excited to have you join us here today for the Law and Policy webinar series. This series is part of a greater dissemination effort linked to the recently released abortion care guideline. While this webinar series is meant to focus on the law and policy recommendations, it is important to note that multiple actions are needed at the legal, health system, and community levels so that everyone who needs it has access to comprehensive abortion care. That's information, abortion management, including induced abortion, and care related to pregnancy loss or spontaneous abortion and post-abortion care. Before we dive in, just a few housekeeping issues. Please note that we will have simultaneous translation available in Spanish and French. Please click the globe at the bottom of your screen and choose the language in which you'd like to listen. We will ask all speakers to speak slowly so that all information can be clearly translated. As a series, it's important to know that today we will review all 7 law and policy recommendations, including their evidence base. In tomorrow's webinar, we will take a deep dive into those recommendations that are related to abortion regulation. While on day 3, we will speak to those more closely related to abortion care provision. After the recommendations are presented, we will open up the webinar to Q&A. We know that many of you may have questions that arise as we are presenting. In all cases, we ask that you place any questions in the Q&A function and not in the chat. This will help to ensure that we are limiting distractions and allow us to do our best to get all the questions answered. This webinar will be recorded and distributed to all those who have registered. It will also be available for later viewing online. More information will come up. So on that note, let's get started. Next slide, please. As many of you know, WHO is a norms and standard setting agency. Guidelines are the fundamental means through which WHO fulfills its technical leadership in health. Next slide, please. In March of this year, WHO launched the Abortion Care Guideline. And as a quick overview, the objective of this guideline is to present the complete set of all WHO recommendations and best practice statement relating to abortion care, with the goal of enabling evidence-based quality abortion care globally. Some previous recommendations remain unchanged. Some recommendations have been updated based on new information, and additional recommendations have been included. This guideline is the result of a development process between 2018 and 2021, involving staff members from both WHO headquarters and regional offices, and a vast range of country expert contributors and support personnel. Global experts in clinical care, health systems, human rights, and law and policy were convened to review the evidence and draft recommendations. In addition to the quality of evidence, several elements are considered when forming recommendations: human rights, as well as a balance of health benefits and harms, sociocultural acceptability, health equity, equality and non-discrimination, societal implications, financial and economic considerations, and feasibility. The final guideline development group also included a youth representative and a human rights advisor. Next slide, please. The guideline is centered on the values and preferences of abortion centers, considering them as active participants in, as well as beneficiaries of, health services. As each individual moves through the abortion care pathway, from pre-abortion, abortion, to post-abortion, this guideline provides information on how service delivery models can be used, where services can be provided, who may safely carry them out, and what interventions are needed. Finally, underpinning all of this is the enabling environment, which is the foundation of quality, comprehensive abortion care. The three cornerstones of enabling
Nous avons
environments are
également jugé
respect
qu'il
for human
était
rights within a
indispensable de
supportive
créer un
framework
environnement
of policy,
favorable dans le respect des
the
droits de la
availability
personne,
and accessibility of
que
information,
la
and
disponibilité et
a supportive,
l'accessibilité des
universally
informations étaient
accessible,
indispensables et
affordable,
qu'il
and
devait exister des
well-functioning
systèmes de
health
santé
system.
propices
Next
ainsi qu'un
slide, please.
cadre propice à l'établissement de
Here are
lois
some
et
key
de
principles
politiques. Voici
underpinning
donc
this
les grands
guideline.
principes qui
Next slide.
sous-tendent cette ligne directrice.
Abortion is a safe,
L'avortement
effective, and
est
non-complex healthcare intervention. Different areas, even within the same country, may require different approaches to designate essential health services and to reorient health system components to maintain these services. However, WHO has included comprehensive abortion care in the list of essential health services. As we will hear more about shortly, restrictive laws and policies regulating abortions have vast impacts, including, but not limited to, risk causing delays in receiving care or abortion becoming inaccessible in practice, impact access to medical procedures only by women, and often disproportionately affect populations in vulnerable situations, including adolescents, women facing financial hardship, and those with less access to education. Inaccessibility of quality abortion care risks violating a range of human rights of women and girls. Next slide, please. Thus, in thinking about how states could take positive steps to secure an enabling regulatory and policy environment, I'm highlighting here some of the potential law and policy barriers that were identified in the 2012 Safe Abortion Guideline as they relate to abortion care. Next slide, please. In this guideline, we specifically looked at both the health and non-health impacts of these barriers encircled, as well as the three additional topics to the right: criminalization, grounds, and gestational limits. We searched and reviewed the relevant evidence for each of these as if they were independent interventions, meaning we looked at the effect of criminalization,
indépendantes les unes des autres.
isolation, grounds-based approaches in isolation, etc. We also looked
Nous avons
at the
également
for a negative
étudié les possibilités de relations négatives avec la jouissance de ces droits de la personne, notamment en ce qui concerne la protection des
each recommendation as a separate recommendation alongside Fiona, it's important to note that for states to be able to take positive steps to securing and enabling regulatory and policy environment, the policy, regulatory, and programmatic barriers must be considered together. Legal actions are needed at not only the legal level, but also the health system and community level, so that everyone who needs it has access to comprehensive abortion care. The regulation of abortion should be grounded on and should promote equality and non-discrimination, and should have the objective of respecting, protecting, and fulfilling sexual and reproductive health and rights, achieving positive health outcomes while meeting the particular needs of marginalized person. Next slide, please. So what kinds of impacts did we look at? Here are some examples: delay, cost to individuals and the system, self-managed abortion, unlawful abortion, referrals, workload implications, stigma, and disproportionate impact, to name a few. We also had outcomes that were more specific to the intervention. So for example, for criminalization, we also looked at criminal justice procedures, harassment, anti-abortion sting operations, availability of trained providers, and reporting of suspected unlawful abortion. Many of these were pre-identified as possible outcomes after a process of legal mapping, which involved a rapid scan for literature reviews, research studies that explicitly address the effects of interventions in question, and causal modeling to identify additional research that does not explicitly assess the effect of law, but reports findings that could plausibly be used in assessing the effects of these laws. Before I go on to the specific recommendations, I'd like to now turn it over to Fiona. Fiona?
Thanks, Antonella. So just to reinforce what Antonella has already suggested here, our focus today and across these 3 webinars and in the 7 recommendations that we are discussing is the regulatory context for the provision and management of abortion. In other words, law and policy. So these 7 recommendations aim to ensure that the regulatory environment supports the provision and receipt of quality abortion care. It is therefore important that we see these 7 recommendations as being interlinked and connected, and as being about the design of the regulatory framework, rather than thinking about them as a set of rules about what individual providers must do in any concrete case, bearing in mind that ordinary considerations of judgment and appropriateness and so on continue to apply. As Antonella has already outlined, supportive law and policy is just one part of the enabling environment for quality abortion care. So as we go through each of the recommendations today, I will give you a sense of the evidence that underpinned these recommendations from both the studies and international human rights law, and the full evidence base is available in the supplementary material to the guideline. As the recommendations are based on this integrated evidence base, bringing together the evidence from the studies and the applicable standards in international human rights law. Antonella?
Great, thank you. Next slide. So I'm going to focus in on our abortion regulation section. And specifically, within this section, we cover criminalization, grounds-based approaches, and gestational limits. Next slide, please. Unlike other health services, abortion is commonly regulated to varying degrees through the criminal law, in addition to regulation under healthcare. Abortion remains a criminal offense in most countries, with penalties against those who have abortions and or those who provide abortion services or assist with accessing or managing abortion, sometimes including those who provide information about abortion. In some countries, all of these actions are criminal offenses. The recommendation is for the full decriminalization of abortion. Decriminalization means removing abortion from all penal criminal laws, not applying other criminal offenses such as murder or manslaughter to abortion, ensuring that there are no criminal penalties for any actor involved in the process. So this includes the pregnant individual or anyone else assisting in the process, whether it is to provide information, performing the abortion, or accompanying the person undergoing the process. Decriminalization would ensure that anyone who's experienced pregnancy loss, miscarriage, is not suspected of illegal abortion. Decriminalization does not make women vulnerable to forced or coerced abortion, because these actions would constitute serious assaults covered by other laws. It is important to note that decriminalization is a necessary step to the legalization of abortion, but further legal or regulatory change will be required to ensure that abortion is available, accessible, and of high quality. So I'll now turn to Fiona to discuss the evidence and outcomes. Fiona?
So for the analysis of the impact of criminalization, we identified 22 studies The studies were conducted in Australia, Chile, El Salvador, Ethiopia, Ireland, Northern Ireland, Mexico, the Philippines, Rwanda, Senegal, Tanzania, Uruguay, and Zambia. And they related to most of our outcomes of interest. The studies demonstrated that criminalization complicates women's pathways to safe and legal abortion and contributes to abortion delay, to the continuation of pregnancy, and to substantial opportunity costs. These include travel, delays in accessing post-abortion care, distress, stigma, fear, and exploitation. The studies also suggested that criminalization is associated with recourse to unlawful abortion and self-managed abortion. They showed that where abortion is criminalized, there are sometimes criminal proceedings against women, and this is something that women fear, even if prosecutions are rare. This impacts also on their recourse to post-abortion care. For health workers, criminalization is associated with a lower availability of trained providers, increased workloads, including work required to avoid criminal investigation, a negative impact on their relationship with patients, apprehension of anti-abortion sting operations, and fears of criminal liability, which leads to a hesitancy to provide abortion care, as well, in some cases, as a willingness to report women suspected of having an abortion. Sometimes the studies showed practitioners do this in order to protect themselves from legal repercussions. Some studies suggested an association between criminalization and system costs, including indirectly by showing that decriminalization impacts positively on birth weight, decreases unplanned pregnancies, and decreases maternal mortality and severe abortion morbidity. The evidence from these studies that we reviewed underlines why international human rights law bodies increasingly call for the decriminalization of abortion and gives substance to the ways in which criminalization impacts on multiple rights, including the right to health, the right to privacy, and the right to equality and non-discrimination. Furthermore, international human rights law requires states to take steps to reduce mortality and morbidity and to ensure that women do not need to have recourse to unlawful abortion. All of this underpins the recommendation for full decriminalization, as Antonella already outlined. Given the ways in which criminalization interacts with many other regulatory interventions, such as grounds or gestational limits, it would be fair to see the recommendation for full decriminalization as being foundational to the creation of a supportive law and policy framework for quality abortion care.
Great. Thank you so much, Fiona. So moving on to our next recommendation. National laws in almost all countries permit abortion under prescribed grounds or specific circumstances, even in settings where abortion is criminalized. So already we are seeing the connections between these recommendations. The circumstances under which abortion is permitted vary widely across different countries, sometimes reflecting clinical indications. Examples might include risks to the health of the pregnant woman or fetal impairment. Some can relate to the circumstances of conception, for example, rape or incest, and some relate to socioeconomic circumstances, such as economic hardship. In some countries, abortion is available on request up to a specified gestational age, which we will talk about shortly, and then limited to specific grounds thereafter. The recommendation is against laws and other regulations that restrict abortion by grounds and recommends that abortion be available on request without justification as to reason. Fiona, can you take us through the evidence?
Sure. So for the analysis of the impact of grounds-based approaches, we identified 21 studies. These were conducted in Argentina, Australia, Brazil, Chile, Colombia, Ethiopia, Ghana, Iran, Ireland, Israel, Mexico, Rwanda, Thailand, the United Kingdom, Tanzania, Uruguay, and Zambia. The data from these studies suggest that grounds-based approaches contribute to abortion delay, the continuation of pregnancy, based on findings that when abortion is allowed on request in early pregnancy, there is a decrease in fertility, and significant opportunity costs, including travel, financial cost, stress, trauma, fear, stigma, being interrogated or questioned when seeking abortion, and having to carry a non-viable pregnancy to term. They also suggest that grounds-based approaches are associated with recourse to unlawful abortion and self-managed abortion. Here we considered also the disproportionate impact of grounds-based approaches and found that they may have a disproportionately negative impact on women with fewer resources or lower educational attainment, rural women, and women who seek abortion on rape or health grounds. We also found that grounds-based approaches increase workload for health workers, including the workload associated with seeking to interpret or apply the law, or preparing paperwork or files for review. That it can result in referrals to providers in a state where there are fewer obstacles to accessing care, and that grounds-based approaches may be associated with system costs, such as indirect contributions to maternal mortality, delay for women with severe health conditions, and directly imposed costs on court systems. It is important to note that these studies illustrated the problematic nature of grounds-based approaches in at least 3 ways. Where there are specific grounds, those grounds might not cover all situations in which women need abortions, or indeed all situations in which international human rights law requires abortion to be available, namely in cases of risk to the life or health of the pregnant person, or where continuation of pregnancy would cause substantial pain and suffering, including but not limited to situations of rape, incest, and fetal inviability. Secondly, where there are grounds, someone must determine whether a person who seeks abortion satisfies those grounds. And that process can create significant delays and inconsistencies because of complex bureaucracy or disagreement between practitioners about whether a ground is fulfilled, as well as creating opportunities for judgment, interrogation, or testing a woman's claim that she fulfills a ground. Third, the existence of a grounds-based approach requires interpretation of these grounds, often by medical practitioners. That interpretation can be inconsistent and sometimes conservative, with limiting interpretation being influenced by, for example, continued criminalization of abortion outside of permitted grounds. Some studies showed that rape and health grounds are consistently interpreted very restrictively. The review thus showed that grounds-based approaches do not work to ensure access to abortion in all situations in which international human rights law requires it to be available, undermining rights, including the right to health, the right to life, and the right to privacy, as well as potentially contributing to unsafe abortion and increased maternal mortality and morbidity, which states are required to take steps to reduce. Hence the recommendation against grounds-based approaches.
Great, thank you so much. Next slide, please. Grounds-based approaches are commonly accompanied by gestational age limits, yet again demonstrating the link between these recommendations. Gestational age limits are time limits that restrict when a lawful abortion may be accessed by reference to the gestational age of a pregnancy. These limits often vary depending on the specific condition under which abortion is permitted and can be imposed through formal law, institutional policy, or personal practice by individual health workers. We recommend against laws and other regulations that prohibit abortion based on gestational age limits. This is a regulatory recommendation. meaning we are not speaking about when abortions should or should not be provided. We know that gestational age limits are arbitrarily set and not evidence-based. Pregnancy can be safely ended regardless of gestational age. Thus, gestational age limits may be relevant when considering methods of abortion, for example. So now I will turn to Fiona to discuss the evidence and outcomes.
We included 21 studies on the impact of gestational age limits. These studies were conducted in Australia, Belgium, Nepal, Mexico, South Africa, the United Kingdom, and the United States of America. The studies suggested that gestational age limits may lead to abortion delay, especially among specific populations, namely women seeking second trimester abortions, those living in areas where clinics are limited and remote, and women who are close to the gestational age cutoff. These delays can arise because women seek abortion after a gestational age limit has passed and thus seek to access it in another jurisdiction, or because of multiple referrals or facility visits before they find a provider willing to perform abortion. Where someone is denied abortion based on gestational limits, getting a referral to another provider can be quite challenging. As might be expected, the study showed that gestational limits do result in disqualification from abortion and contribute to women continuing their pregnancies because they are denied abortion due to gestational age. Among the opportunity costs that are identified in the studies are those associated with being denied abortion, which include financial and educational costs that can persist for many years. Some studies suggested that women may seek unlawful abortion or attempt self-management where they exceed gestational limits. Importantly, 7 of the studies we included showed that gestational limits impact disproportionately on key populations, specifically adolescents, women with cognitive disabilities, women living remotely from abortion clinics, and women with lower levels of educational attainment or lower levels of income. System costs include increased rates of maternal mortality and poor health outcomes. International human rights law does not expressly prohibit gestational age limits, but it does require states to take steps to reduce unlawful abortion, to decrease mortality and morbidity, and to ensure that abortion is available in all cases where the life or health of the woman is at risk, or where carrying a pregnancy to term would cause the pregnant person substantial pain or suffering. This obligation applies regardless of gestational age. The Human Rights Committee has made clear that restrictions on the ability of women or girls to seek abortion must not jeopardize their lives, subject them to physical or mental pain or suffering, discriminate against them, or arbitrarily interfere with their privacy. The evidence from these studies suggests that gestational limits are associated with these impacts and are thus a regulatory intervention that does not respect, protect, or fulfill the rights of pregnant people.
Great, thank you so much. Before I go on, let me just highlight that we posted in the chat a link to the evidence to decision frameworks so that you have that information available to you. That reviews all of the evidence that Fiona is outlining now and all of the findings. So to continue, now moving on to the recommendations contained within the pre-abortion section. Here, I will focus on mandatory waiting periods, third-party authorizations, provider restrictions, and conscientious objection. Next slide, please. In many countries, women are required to wait a specified amount of time between requesting and receiving an abortion. These imposed delays are known as mandatory waiting periods. They can be required by laws or regulations and/or administrative procedures imposed by facilities or individual providers. Waiting periods may commence at various points, including at the time of first request, during consultation and/or counseling, or after a service provider has sent the required notification to an operative body, for example. Waiting periods may also vary depending on the ground or specific circumstance, upon which the woman is accessing the abortion, as well as the gestational age, again, demonstrating the interconnectedness of these recommendations. We recommend against mandatory waiting periods for abortions. Fiona, over to you.
So for this intervention, we considered 33 studies, all of which were conducted in the United States of America. These studies showed that mandatory waiting periods contribute to delayed abortion, with the delay magnified if multiple visits are required. The continuation of pregnancy, especially among adolescents and women of colour, and significant opportunity costs, including financial and emotional opportunity costs, logistical burdens, stress, travel time, and out-of-state travel. Online or phone-based counselling was shown in the studies to mitigate some opportunity costs related with 2 visit requirements. The negative impacts of mandatory waiting periods are disproportionately felt in the studies by women who need to travel further for abortion, women of colour, and women with fewer resources. The studies also suggest that mandatory waiting periods increase health worker workloads and are associated with system costs. International human rights bodies have encouraged states to repeal and not to introduce mandatory waiting periods, which they recognise as operating as barriers to accessing sexual and reproductive health care. And the evidence from the studies we considered demonstrates the implications of waiting periods for rights such as the right to health, the right to privacy, and the right to equality and non-discrimination. We thus recommended against mandatory waiting periods.
Great, thank you. Next slide. A third-party authorization is a requirement imposed by law or policy or in practice that someone other than the abortion seeker must authorize an abortion, even where other applicable legal requirements for lawful abortion have been met. So the person qualifies based on grounds or gestational age limits, or have completed the mandatory waiting period, just to name a few, and still another person is needed for them to access that abortion. Typically, an additional authorization is required by a parent, a guardian, a spouse, a partner, health worker, health authority, or judicial authority. These requirements operate whether or not the person who seeks to end a pregnancy has the capacity to consent to medical treatment, meaning that there's no consideration of those with the ability to consent or evolving capacity by minors, for example, which is often done for other services, including antenatal services. We recommend that abortion be available on the request of the woman, girl, or other person without the authorization of any other individual, body, or institution. We do note that involving a parent or partner in the decision-making process must be the pregnant person's choice and not the result of requirements of third-party authorization. Fiona, can you walk us through the evidence?
Sure. Here we identified 34 manuscripts. 31 of these related to the United States of America. The 3 other jurisdictions were Hong Kong, Tunisia, and Turkey. 23 manuscripts considered what they termed parental involvement. In these manuscripts, the precise form of involvement was not specified, but some involvement by a parent was mandated by law. 6 manuscripts considered judicial bypass, while a further 3 studies considered comparatively the impacts of judicial bypass and requirements for parents to consent before a minor could access abortion care. 2 studies compared the impacts of parental consent requirements and parental authorization requirements, and 1 study considered the impacts of spousal consent requirements. Overall, the study showed that third-party authorization requirements are associated with abortion delay, continuation of pregnancy, opportunity costs, recourse to unlawful abortion and self-managed abortion, and abortion seekers' anticipation of exposure to interpersonal violence or exploitation reproductive coercion, and family disharmony. While mitigations such as judicial bypass might alleviate some of these concerns because a minor could choose to go to court rather than get consent of their parents, those mitigations, like judicial bypass, were also associated with delay, opportunity costs, and so on, and were themselves forms of third-party authorization. The data from these studies underpinned international human rights law's position on third-party authorization requirements. International human rights law bodies have characterized these requirements as barriers to abortion that should not be introduced at all, or which should be repealed where they exist. They have made it clear that states may not restrict a woman's access to health services on the ground that they do not have the authorization of husbands, partners, parents, guardians, or health authorities because they are unmarried or because they are women. In addition, states are required to recognize children's and adolescents' evolving capacity and their associated ability to take decisions that affect their lives, including on sexual and reproductive health. Thus, we recommended against third-party authorization requirements.
Great, thank you. In many countries, laws and policies restrict which type of health workers may lawfully promote abortion care. However, abortions may be done safely using tablets, i.e. medical abortion, or a simple outpatient procedure such that most no longer require a specialist or even a general practice doctor. The abortion care guideline provides guidance on how to involve pregnant individuals themselves. Specifically, we have recommendations related to self-management, as we've had prior, as well as a wider range of health workers in abortion care. This is consistent with WHO's support to the optimization of the roles of health workers to address health system shortages of specialized healthcare professionals, reduce costs, and improve affordability, improve equity and equality in access to healthcare, and increase the acceptability of health services for those who need them. We recommend against regulation on who can provide and manage abortion that is inconsistent with our guidance. Fiona?
So for the impact of provider restrictions, we identified 7 studies that were undertaken in Australia, Ethiopia, Nepal, and the United States of America. These suggested that provider restrictions are associated with delayed abortion, significant opportunity costs, including distress, waiting times, and financial cost, and recourse to self-managed abortion. For health workers, the studies suggest that provider restrictions increase workload, largely established indirectly by demonstrating the workload benefits arising from task sharing. International human rights law increasingly reflects the proposition that the availability and accessibility of abortion, rather than its mere legality, is of critical importance to ensuring the effective realization of a wide range of rights, including the right to health and the right to privacy. As a matter of international human rights law, states should ensure that the regulation of abortion is evidence-based and proportionate. The right to sexual and reproductive health obliges states to ensure that healthcare facilities, goods, and services are available, accessible, acceptable, and of good quality, which the evidence from this review suggests is undermined by non-evidence-based provider restrictions. We thus recommended against provider restrictions that are inconsistent with WHO guidance.
Great. Conscientious objection or conscientious refusal is the practice of healthcare professionals refusing to provide abortion care on the basis of personal conscience or religious belief. In some countries, conscientious objection is expressly regulated through employment law, employment contracts, or the law on abortion. WHO has also advised that health services should be organized in such a way as to ensure that an effective exercise of the freedom of conscience of health professionals. In the professional context, does not prevent patients from obtaining access to services to which they are entitled. We recommend that access to and continuity of comprehensive abortion care be protected against barriers created by conscientious objection. It is critical that states ensure compliance with regulation and design or organize their health systems to ensure access to and continuity of quality abortion care. We reviewed the evidence related to the impact of conscientious objection, which Fiona will speak about in 1 minute, not on the effectiveness of regulating conscientious objection. We are, however, looking at this aspect currently. But for the purposes of today's discussion, I'll ask Fiona to come in now to speak to the impact of conscientious objection.
So for conscientious objection, we looked at 25 studies that were conducted in Australia, Brazil, Colombia, Ghana, Italy, Mexico, Nigeria, Norway, Portugal, South Africa, Slovakia, Switzerland, Tunisia, the United Kingdom, United States of America, and Zambia. The studies suggested that conscientious objection is associated with abortion delays, sometimes disproportionately impacting women living in rural areas and being greatest where conscientious objection is prevalent, where conscientious objection policies are inconsistently implemented, or where regulations relating to conscientious objection are not followed. The study showed that conscientious objection is associated with significant opportunity costs, and a pervasive indirect opportunity cost was uncertainty of options. There is significant variation in how and when conscientious objection is implemented, which creates uncertainty in abortion seekers about the obstacles and options that they would encounter. Healthcare providers who claim conscientious objection, our studies show, sometimes attempt to prevent abortion by providing misleading information and may also stigmatize the abortion seekers. The studies showed that some providers claim conscientious objection on a case-by-case basis, which leaves access to abortion unpredictable and contributes to opportunity costs. Some objectors do refer patients, particularly in order to prevent them having recourse to unlawful abortion, but evidence from 11 of these papers suggests that objecting providers implement the referral requirements differently. Only one of the papers reported that most objecting providers were willing to refer. International human rights bodies recognize that conscientious objection is a barrier to accessing abortion and undermines women's human rights. They have repeatedly stressed states' obligation to ensure that provider refusal is not an obstacle to accessing abortion, and the requirement to take effective steps to prevent objectors from undermining the right to the highest attainable standard of sexual and reproductive health. International human rights law provides some guidance as to how states can ensure that the human rights of abortion seekers are respected, even in the context of conscientious objection. And these include organizing the health system to ensure sufficient non-objecting providers are employed and distributed fairly, putting in place clear and enforceable regulation of conscientious objection, ensuring adequate enforcement of that regulation, outlining clearly who may object to what components of care, prohibiting institutional claims of conscience, requiring prompt referral, requiring respectful and non-punitive exercise of objection, and prohibiting conscientious objection in urgent or emergency situations. And so that underpinned our recommendation on conscientious objection.
Great, many thanks. Okay, so we are now at the 10-minute mark before the close of our guideline. So we apologize for the initial delays, but we would like to open it up for some questions and answers. So we're asking people to put these questions in the Q&A at this time. Fiona, I'll ask you to stop sharing. Perfect. And so we'll take a couple of questions for these first few minutes, and then we'll turn back to get everyone ready for the next 2 webinars that are to follow. So just very quickly, as I've mentioned prior, all of this information can be found in our evidence to decision frameworks, which have been posted in the chat. We appreciate the additional comments that have been posted about stigma and other people's work, so that's fantastic. Specific recommendations will be addressed in webinar series 2 and 3 to follow. And at that time, we will provide additional information about different ways in which countries have mitigated some of their existing law and policy frameworks and what they've done to mitigate the effects. So we will have to address some of these more closely tomorrow and the following day. One quick note, again, to highlight that our gestational limit recommendation is a regulatory recommendation. It is not one about when abortion is defined or not defined. The question of viability is not one that is addressed by the recommendation, because again, we're talking about, this is a regulatory recommendation. And in terms of specific conflicts, I'll turn it over to you, Fiona, about the consent requirement.
Yes, so we have a question here from Joe about how to navigate conflict between a consent requirement for minors and the recommendation involving third-party authorization requirements. I think here you are referring to a situation where the law requires a healthcare provider to seek consent from a parent or authorization from a parent for abortion. So if that is the case, if the law requires that, you know, there is the primary approach here would be to seek to advocate for a change in the law. And in most countries, the law will recognize that an adolescent can consent themselves to healthcare, but might make abortion and sometimes contraception an exception to that general provision. So, you know, it's important to try to advocate around changing that. But I just want to note that in some countries, like in Ireland, where I am from, the law does not require any consent or involvement of a parent, but the guidance that has been developed by the medical colleges does require involvement by some authorities, social welfare authorities. That is not required by the law at all. And that's an example of a place where you could look at the prevailing practice and ask whether what is commonly done is actually required by law. If it's not actually required by law, then the recommendation might help to help people feel comfortable with changing that practice. If it is actually required by law, then of course you're working in advocacy for legal change.
Great, thank you. Okay, just a couple of other comments here from the question. Okay, so first, just to mention that conscientious objection will be covered in full detail in webinar number 3, and we can discuss ways in which we might be able to tackle that issue. I'm just looking here in the chat. Some additional. Okay, and then also just some comments here. Don't see any additional questions. I'll ask my colleagues here to confirm. Okay, so it looks like we're okay for the moment. I will ask Fiona if you could start sharing again, please. Great. Okay, so just to wrap up, next slide, please. The guideline, as a reminder, can be accessed in multiple formats, digital format, in PDF format, as well as our executive summary, which includes the recommendations all in one place. And these are also available in multiple languages. And the links are here, and this information will be shared. Next slide, please. There will be several derivative products that are being developed that are based on this updated and consolidated guideline, and that includes the operational guidance containing details on implementation, the evidence brief for law and policy recommendations, as well as additional materials such as the updated version of our clinical practice handbook and specific tools for health workers. Next slide, please. There are also other resources available on abortion care, and so you can come to our topic page on abortion. We have social media tiles, the Global Abortion Policies database, as well as several articles and fact sheets. Next slide, please. And so before we close today, I will just turn it back over to Fiona for some final thoughts, and then I will tell you about how you can access more information. Fiona?
Thanks. So we just wanted at this point to note that all 7 of the issues that we address in these recommendations pose barriers to abortion and have negative effects on human rights. But that barriers and harms sometimes result, as I said in my answer to the earlier question, from how law and policy are applied in practice and not only from the content of the law itself. For example, women are sometimes subjected to unnecessary demands like requiring spousal consent, even if the law does not actually require this. Or they are refused abortions where a health worker considers the woman even undeserving, even if her case is permitted under existing grounds. Examples of factors that impact how abortion-related laws and policies are applied in practice to limit access to abortion include a lack of clarity, a lack of guidance, biases, lack of knowledge or understanding of the law, or facility-level policies that are more restrictive than the law actually requires them to be. Thus, it is important when we are thinking about implementing law and policy, and we'll be talking about this more over the next 2 days, to be conscious of what might already be done or what might be possible to do to move closer to these recommendations without necessarily needing to change the law. And also to ask whether these practices exist that constitute over-compliance and that could be immediately ceased as a step towards a more supportive law and policy environment. And so, as I said, we'll talk more about that in relation to each of the recommendations over the next 2 days.
Great, thank you so much. So we've completed today's webinar, but we invite all to participate in tomorrow and Wednesday's webinar, where we will do a deep dive into the recommendations with our distinguished panelists. And if you've not registered and you'd still like to do so, please see the links in the chat. Next slide, please. One more note, if you've enjoyed the webinar, you will be able to view it again and share it with others. The presentation will be shared in PDF format, as well as the links to the recordings in a few days. Please note that when we do the deep dive into the recommendations, you'll have an opportunity to ask specific questions about how you can engage with these recommendations in your country context then. But we will only focus on offering evidence around these recommendations at these times. Next slide, please. We also invite you to stay tuned for future webinars. If you're not already a member, please join the IBP platform. It's a digital space where you can get updates on other upcoming SRHR webinars and events, receive news about the guidelines and other tools, and interact with and exchange knowledge with people around the world who share an interest in a variety of SRHR topics. Signing up is free of charge, and you can simply go to the ibpnetwork.org. Next slide, please. Being a member also allows you to join a range of communities of practice, including one on comprehensive abortion care. And doing so allows you to engage in discussions, receive updates on abortion research, share your own work, and pose questions to others in the community. Next slide, please. Thank you for your attention. Please do join us for the remaining webinars as part of this series, and keep an eye out for additional webinars on the platform. Thank you.